I want to thank all of our judges and our live and gallery poster presenters. We will announce the winners this evening at the conclusion of the event. Just a reminder, the poster gallery will be open all day today. Also, as a reminder, please tweet your favorite poster or session at JPS. One of my favorites this morning was the addition of SGLT2 inhibitors in patients with heart failure reduced. The addition of the SGLT2 inhibitors in patients with heart failure reduced 30-day hospital readmissions. So please tweet your favorite poster or session this morning. And then at the end of the symposium today, you will receive a survey. So please submit your comments regarding your experiences today. So as we move into our keynote speaker today, we have the pleasure of Amanda Arazola joining us, and she will be introducing our keynote speaker, Dr. Marcela Nava. But before we get to Dr. Nava, Amanda Arazola serves as the North Texas Program Officer for Asset Funders Network and also serves as the co-founder and chief analyst for COACT North Texas, which is a nonprofit that focuses on human-centered design to promote innovation within nonprofit organizations and business entities. She is a sixth-generation Texan, and she was appointed as the first Latina to serve on the Tarrant County Hospital District Board of Managers, or JPS Health Network, by Commissioner Devin Allen, Precinct Number 2. Amanda is a dedicated community advocate, nonprofit executive professional, and leader with over 20 years of dedicated work in economic security, healthcare, and Latina literacy. Amanda, please join us.
Good morning, all, or almost afternoon. Thank you, Melissa, for the introduction. I'm so excited to be here and to review and look at all the wonderful presentations that are happening today and all of the posters. It makes my heart very happy in seeing JPS still continuing this research quality symposium and through the hard work of all the staff members who make this possible. As we know, our community in Tarrant County, we have a particular population that is growing and that is in need of additional health supports. So it takes a village, it takes a team to be able to do that. And I'm so proud of all the work that JPS does in these particular realms. I am super excited this morning to be able to introduce you all to a personal friend that I met a couple of years ago in doing advocacy work and in promoting health services and equity within health. Dr. Marcela Nava is a health equity professor and dedicated in policy and research. And so that's how our paths have crossed before, because understand the hard work that's happening, especially in our Latina communities, and how are we continuing to help support those communities and moving forward, and what are those intersections and cultural differences mean to healthcare and to healthcare at large, from practitioner to administrator to county government to all in between. Marcela's work and her current research focuses on the intersection of political, economic, and social contexts of immigrants and other marginalized groups in the U.S. As a sixth-generation Texan, we like to say we didn't cross the border, but the border crossed us. However, we know that in this system and in this world, all of our communities are lumped together. So we have to have empathy, and we have to be able to create opportunities for individuals as if they were our citizens. Healthcare is that particular right. And so what she does is she studies the way that institutions influence health and develop multi-level, innovative, and common sense approaches for community health improvement. In the past, she's practiced social work, which is near and dear to my heart. I am a social work practitioner at the core of my being. She also has worked with homeless and runaway youth, families at risk of child abuse, and immigrant and refugee communities that had overseen various federal funding program, community-based participatory research projects focused on women's health. As an educator, she teaches graduate and undergraduate courses in social research methods, immigration and health policy, and community-based practice. She is overall a wonderful individual and a badass chingona, as we like to say, in being able to be one of the 1% of Latinas with a doctorate degree. So I am proud and happy to introduce you to Dr. Maricela Nava.
Thank you for such a kind introduction. I am so happy to be here today. Today is such an important day for me in so many ways to be here with you all, and I'm excited to get to continue this conversation. So let me make sure that my screen, am I sharing? No, not yet. All right, so while I'm making these slides load, just to touch on a little bit of what Amanda said, my path to be here in front of you today has been, as are many of our paths, a little bit not circular, but definitely I went through a lot of different stages to try to figure out essentially what can we do about the inequities that we're experiencing. As a social worker working at the front lines of a lot of what our families and youth are going through, I saw my perpetual challenge was to run into the barriers, the circumstances, the limitations of our political system, of our policies, and continuously keep looking for what works. Because it became clear at one point that simply delivering interventions at a community level wasn't going to be effective if certain policies remained in place. I ended up doing a lot of work in health and health policy for many reasons. And a large part of that is because of how universally important this idea of health is, and especially right now and where we are as a country, as a nation. But along the way, this was the primary question: what works? And so to really get to a point where I could begin to consider what works and to ask you to then allow me the privilege of sharing with you my thoughts around that. A large part of this trajectory for me has been combining the different perspectives that really are required to be able to have an honest conversation about this. Because even though I sit virtually before you today as a PhD with a background in policy and public health and social work, despite my many, many years of education and many incredible opportunities, it would not be in any way authentic for me to step into this space without first and foremost acknowledging that I was born at JPS Health System. I was born at, back then we just called it John Peter Smith Hospital, back in the early 80s. And I was born to a mother who at that moment was undocumented. So from my very birth, I want to be clear that from my very birth, what I'm talking about here, which ended up being a research focus for me in many ways, it was trying to understand and contextualize my circumstances. And over the years, realizing that my circumstances, while they may be mine, are certainly a set of circumstances that are shared far and wide by many, many other children of people who came to the US for a better life, of many of the other families who have had to experience a lot of different structural barriers and fulfilling, and living the best life possible. So I'm sitting here before you today, again, as Dr. Nava, but also as the child of a mother who was not eligible for any type of health insurance when I was born. So we're all sitting here today. We're all joining here today because at the end of the day, it's important to note that we all have a core mission. Even though we may have different levels of awareness different competencies, different types of professional or disciplinary training. At the end of the day, it's fair to assume that everybody in this space wants there to be a better patient and family experience. We want to see improvement in quality. We want to see improvement in outcomes, and we want to see improvement in access to care. And so I think that is the driving platform that I really want to make sure to start with. And unfortunately, one of the things that we don't do, or things that we could definitely do a lot more of, is to build cross-sectoral collaboration. So this is just a quick representation of some of the many groups I've worked with, and this is just in the last few years. But just to really emphasize that it is impossible to do this kind of work without having broad-ranging collaborations. And one of the things that I've really had the privilege of getting to participate in lately is a program through the Robert Wood Johnson Foundation, Health Policy Research Scholars. And if you're familiar at all with the Robert Wood Johnson Foundation, you're familiar with this idea of a culture of health. So I won't bore you with the description of that. But keep that idea in mind as I'm going through some of the ideas I'll be sharing today. What does it really mean to create a culture of health? What does it mean to reduce inequities? What does it mean to protect community health? But more than anything, what does it mean to be honest with ourselves as humans that are in a system where we are not simply passively providing services and hoping that we do it in the best way possible. We ourselves are agents in political and economic systems. We ourselves as individuals have limitations, have professional conflicts, have different types of biases. So what does it mean to put ourselves in that space, but put ourselves in that space for the purposes of being politically conscious? And so I'm going to put that term out there. And that's not a term, for the record, that I've seen published anywhere. And it's a term that we've used loosely in different spaces to be politically aware, to politically conscious. So today the challenge is, how can we be politically conscious as researchers and as practitioners? What does that mean to do politically conscious medicine or politically conscious research? So let's talk a little bit about that. Now, one of the easiest ways to, the challenge when you're in the kind of work that I do is that it's really hard to describe to people, because I don't focus on a type of health area or health policy. I look at how things connect. And so one of the ways that I look at how things connect is in the field of cancer care and cancer services. This is a really easy space for folks to have conversations, because when you think about the basics of the cancer continuum and how many different types of individuals and organizations are involved in everything from providing education, prevention, to detection and diagnosing services, actual treatment, long-term survivorship. This is a really important space where we see a lot of healthcare services, a lot of social service providers, a lot of public health, a lot of quality improvement and research. So I'm going to tell you a bit of a story to try to drive home the idea of what it means to be to practice politically conscious medicine or research. So let's think of just the basic idea of when we talk about cancer and just how we talk about those different conversations. So whenever in population health research, and we talk about cancer health disparities, we're looking at population health statistics. So we're looking at a large group of people, and we're trying to look at screening rates. How often are people getting screened? How many new cases are there? How many overall cases are there? How many deaths? How long do people live after their diagnosis? At what point are people getting diagnosed? And these are all very, very important things to consider from a research perspective. Obviously, we want to know where those disparities are, but it's incredibly important to note that a lot of what we do is based on what we measure. And so when you talk about, say, population health statistics that have to do with new cases of cancer diagnosis, well, I want you to remember that there is a process. There's a literal process of human beings that are reporting these statistics to state agency that compiles these statistics. And those reports are often flawed. They often have missing information. They're not always perfect. And importantly, they can only share what they capture. So when we start talking about political consciousness, think about one of the basic political categories we'll be talking about today, which is immigration status, and how that is or isn't captured in official statistics. So anything that we do, an honest, politically conscious conversation acknowledges that we can only address what we measure. And what we don't measure, we don't have to offer a solution. So even the process of collecting information and what variables we choose to capture, that is a political decision, because that can either silence and rend entire communities invisible, or it can bring their issues to the forefront. So it does not matter if you are not the one collecting the information. The fact that you are the one working in a space where you are limited to statistics that do not give the full picture of what people's experiences are, that in and of itself is a political decision. And you'll see me introduce these different types of examples as I go along of what this idea of political consciousness might mean. So exactly what does that mean? So again, to share the story that actually brought me to the table to sit down with Mandara Zola and a lot of the amazing folks that I've had the opportunity to connect with at JPS, I got a chance to actually the pandemic makes everything. My time frame is off, but a few years ago, I got a chance to connect with a researcher who was really focused on this very basic reality that has long been known in public health research, which is the fact that in certain parts of the country, we know Hispanic and immigrant women are more likely to die from cervical cancer than other women. And regardless of what your focus is in terms of healthcare, it's really important to note that cervical cancer is a very, very interesting thing to examine, because cervical cancer is a very, very highly preventable and treatable cancer. Most forms of cervical cancer are caused by the virus for which we have a vaccine in place, and regular screenings, regular woman's pap smears are very, very, very effective at catching cervical cancer early, and existing treatments are very, very effective. And so most public health researchers will let you know cervical cancer is something that could be eradicated given the tools and technology and healthcare services we have right now. So when you see a group of people that are more likely to die, and we're not talking just to be diagnosed with, but to die from a preventable and treatable cancer, that points to huge, huge gaps in the healthcare system. Because again, this means that this isn't a rapidly form of progressing cancer. This means that the healthcare systems around a woman, around a person with a cervix, have been failing them over years and years and years as a period of time. This is not something that is a rapid crisis type of condition. So when I got a chance to meet with this researcher who was focusing a lot of their work on Texas, again, just because we have a large enough size of Hispanic women in counties, they came to Texas in a way that I really, really appreciate. And that was, rather than simply trying to say, let us document everything that could be wrong, they really came in here with the idea of saying, let's figure out what are some possible things that we can do about it. What is already happening that might help us identify a solution? So I'm not going to bore you, and I'll let their work speak for itself in terms of their approach to that. But that in and of itself, I really want to point out, is a politically conscious way of doing research. They entered this research space knowing that it wasn't enough just to document these disparities. They entered this research space knowing they wanted to identify potential policy levers. In other words, what are different things that we think are contributing to this, and how can we use this study not just to highlight the disparity, but to highlight what can be done about it. Very politically conscious approach. Now, part of doing that was the research team made a point to look at not just, again, let's document disparities, but let's look at what fits the pattern. So if we know that there are certain patterns that are going to fit, generally in terms of Hispanic women and diagnosis and different disparities around cervical cancer, Texas being large enough, we can do a comparison. Are there cases where it doesn't fit the pattern? So what their study revealed is that Dallas County, right, our neighbors to the east, are fairly similar to the state at large. Bexar County, which houses San Antonio, women are doing significantly better than would be expected. But the really interesting part was Tarrant County, because Tarrant County did not fit this. And in fact, Tarrant County people are doing worse than other areas across the state. And this is when I really became fascinated and wanted to make sure that this research reached our community, and why I'm sharing this today, because what this study revealed is that once you took into account these different counties and how they compare to the norm, when you sit down and you compare Dallas County and Tarrant County side by side, counties that have very, very similar groups of Hispanic women, very, very similar groups in terms of no major differences in terms of different types of behavioral factors and other conditions. When you look at when you look at just that comparison alone, women in Tarrant County, Hispanic women in Tarrant County, are 1.4 times more likely to die from cervical cancer than their counterparts in Dallas County, even though they're getting diagnosed at the same rate. Okay, so I'm going to say that one more time because that's a really important point here. Hispanic women in Dallas County are 1.4 times more likely to die from cervical cancer, even though they're getting diagnosed at around the same rate as women in Tarrant County. So there is something happening. There's something happening at a county or at a political level that means that even when diagnosis is happening at a similar rate, something is happening between that diagnosis and the survivorship that is putting women in Tarrant County, Hispanic women and their families in Tarrant County, at a significant disadvantage. So what these studies did, again, this is a fairly recent study, and there's so much that we can unpack here. Part of what the question, that the researchers did was look at, is this concentrated in specific zip codes? So there is data that we can look at that looks at the zip codes. And one of the things that is a really important next step for a lot of researchers right now is to examine those communities and look at what are the demographics of people in those communities, what types of healthcare access do they have, and how does where they live shape. But I told you at the beginning of this that part of the point of this presentation is politically conscious medicine and research. And so that requires not just documenting the disparity over and over and over again, because let's be honest, we've done as researchers a really good job over the past 20 years, 30 years or so, of documenting disparities, of trying to figure out, of trying to explain under what conditions and in what circumstances and with whom. But what we don't do well is actually find the solutions and actually put together plans that take that research and drive it into actionable things that make a difference in people's lives. So if we're going to talk about politically conscious medicine and research, part of this is realizing that sometimes the lens that we're using, we're missing some of the best information because we're so focused on the disparity. We're not looking at what happens when the disparity doesn't exist. What happens when that disparity isn't there? Is there something already happening that we can build on that is a solution, a potential solution? So to contextualize a little bit about what this means and how this relates to a conversation about cancer, cervical cancer and county, many of you are probably left wondering what is happening in Tarrant County and what does this have to do with what we're talking about? So politically conscious approaches understand that we live in a healthcare system that has many, many, many different influences and sources of accountability. We know that we are accountable to state and federal tax regulators and private health insurance, managed care corporations, and local politics and global politics and community factors. So health is not created, and healthcare systems are not created in a vacuum. We know that this also is a large part of the fragmentation of our healthcare system. So if you were to go into, so when you talk about Texas and you are talking about just prevention and screening services, for example, well, there are state funds for that. There are state funds for that are funded, that a large part of those come through federal government for public health efforts. And those are generally open and available to most people. Now, if you read carefully, this is a sample of the website Healthy Texas Women, which is Texas's program that provides different types of benefits for low-income, underinsured women. And so when you read here at the bottom, what if I am diagnosed with breast or cervical cancer? What if this is a fair question. What if I receive services here and I am diagnosed? Then at that point, you may be eligible to receive Medicaid benefits from Medicaid for breast and cervical cancer. So consider a person that goes and gets a cervical cancer screening, is diagnosed with cervical cancer. They are referred to Medicaid for breast and cervical cancer. But in Texas, to receive Medicaid for breast and cervical cancer, I want you to look at the second to last bullet point. You must be a U.S. citizen or eligible immigrant, which generally means being a lawful permanent resident for more than 5 years. So that means that it is very likely that you may receive a diagnosis of cervical cancer, but not be eligible for state Medicaid funds to treat that cancer. So what happens? I won't bore you again with the conversation and discussion, but I'm happy to answer questions about what these categories are in terms of eligible immigrants. But what happens when you have cervical cancer and you don't qualify for state funding? Well, in the state of Texas, the responsibility then falls to counties to provide services or fund healthcare assistance for people who are uninsured or uninsured. Now, part of being politically conscious is understanding that within the state of Texas, almost 20 years ago, there was a series of decisions that began at the state level that continue to be in place to this day. At that time, about 20 years ago, there was a question that arose from a public hospital district in Texas saying, basically, if somebody is undocumented and is not eligible for Medicaid under federal law, do we have to provide services to them? And this is, again, a county hospital district that really presented that question. And the response from Greg Abbott then, back in 2004, was the Attorney General of Texas. The response, the interpretation was that a hospital district, such as the Tarrant County Hospital District, JPS Health Network, is allowed to, but is not required to, provide non-emergency public health services to undocumented persons who are otherwise ineligible. Now, this is a legal opinion, and so we could again dissect the terminology here, and I'm happy to again make a note of this if there's something that you want to talk about in terms of the legal conversation here. But the long story short of is that Tarrant County Hospital District has exercised its choice as permitted under this legal opinion, to not provide non-emergency public health services to undocumented persons. So what that means is that somebody with cervical cancer in Tarrant County is not going to be eligible for those services through JPS Healthcare Network, not eligible for treatment, even though that same thing is not true of Dallas County, which does not have a similar policy. So Tarrant County is the largest urban county in Texas to choose to not extend those services to people who are undocumented. Now, a lot of this is, again, there's so many factors swirling around. We could talk about policy. I could talk to you about the statistical nightmare of trying to show that one policy is responsible for one health outcome. but I'm pretty sure you didn't come here to hear me talk about econometrics or anything. I did want to make sure that I could go back and look on my own as kind of a follow-up with the research that I was talking about that was funded through the American Cancer Society. And I wanted to make sure to take kind of a larger look at it, because if you think about a policy that was in place about 20 years ago and the consequences of that policy, if 20 years ago there was a message that went out in Tarrant County to people saying, where the community basically heard, if you are undocumented, you're not going to qualify for preventive or routine healthcare services here in this hospital district, is that going to have an impact on people? And if so, how long will it take for that to make an impact on people's health? And in what ways? These are the kinds of questions that you can only ever really speculate about, because you can't ever definitively say this one policy caused this. But I can, on top of everything else we've talked about, I can share that if you were to look at the counties that have at least a population of 1 million Hispanic women or more in the state of Texas, and you compare their incidence rate, you'll see two types of statistics here. One is called an incidence rate, how frequently they're diagnosed with cervical cancer. And then further on the right, you see mortality rate. How often are they dying from cervical cancer? Even in this, you see that Tarrant County tops the chart. Tarrant County tops the chart in terms of women who are dying from cervical cancer across the state, across large urban areas, and across across areas that are much more rural and have smaller populations overall. So something is happening in Tarrant County, and this is part of being politically conscious, trying to understand what is this and how are we all part of this. So I'm going to jump ahead a little bit and give you some examples and just different ideas to reflect on from some different pieces of research that I've done, and hopefully that can create some interesting questions for you. One of the things that I've heard a lot as a social worker, being in this community for as long as I have, is the question of what happens when somebody is having a health crisis, especially when it comes to different types of women's health cancers. One of the most common things that you'll hear people talk about is the conversation about whether they're going to redirect people to Parkland, to their neighbors to the east, because Tarrant County because they may have just so many challenges in trying to access care. Now, this is, again, just anecdotal. Conversations. I could, probably at one point would need to do a study to share how common that is. But it's really critical to realize, though, that what this means is that it's very likely that for the past 20 years, there has been a pattern of people going to Parkland to receive treatment for cancer for different services that they are not eligible or they don't see themselves as being able to access in Tarrant County. So that means that there is a very interesting politicized relationship now happening at a healthcare space as well, because these are Tarrant County residents, people that pay Tarrant County taxes, that are receiving care outside of the county because of the limitations in the policy for Tarrant County. So there is a lot happening. And the people that work in these spaces, social workers that work in these spaces, these are politicized spaces. They know these challenges. And so a lot of what people find themselves doing is finding really innovative and creative and interesting ways to go around the system or to find the loopholes in the system. And if I was to sit down and talk to everybody in the audience, I am certain that I would probably find 20, or 30 more examples from all of you with experiences similar to this. What happens when somebody has chronic kidney failure and they're unable and they don't qualify for a kidney transplant? Many, many, many examples that I'm sure many of you could share more about how they may work with the healthcare staff to circulate through the ER as needed to qualify for services at an emergency level, to get dialysis, to, again, just simply sustain and not to improve. So focusing on the big question here, which it's so easy for us to get overwhelmed. It's so easy for me to get overwhelmed with the level of need, the complexity. It is so easy to stop and realize how challenging it is to be in this system. And one thing that we often don't like to talk about, but is simply a reality for many of us, is that we do live in Texas. We live in Texas, and we live in Texas in a space, in a time of and a time across the globe, across the world, but it's just here where conversations about health and immigration and who is worthy and deserving of access to care are everyday conversations in our political system, so much so that we ourselves have to be considerate of that. So many of the nonprofits I talk to on a regular basis have to make decisions about whether they will vocally support a vulnerable group or risk alienating a donor that's a huge contributor to another program. So you've got leaders having to make decisions every day in a very, very polarized political environment. You also have, again, what we talked about in terms of a lack of insurance and access to equal cancer treatments. At the same time, when you go into, in the original study that I discussed from the American Cancer Society, when folks go into the communities and they actually ask people, hey, how is it that folks here in San Antonio, where you are being shaped by the same types of broader state and federal policies, how is it that here people are doing so much better than would be otherwise expected? Folks talk about community engagement for survivorship care. So they talk about the role of nonprofits, the role of community groups, and importantly for our conversation today, folks really acknowledge that they live in more supportive medical and payer environments for undocumented immigrants. So I'll say that again. What does it mean to have a more supportive medical and payer environment? Right? What this is telling us that even though we live in a very, very polarized political environment, it is still possible to reduce the impact of some of our political factors by creating more engagement and a more supportive medical and payer environment. That starts with us. So I'm going to introduce you to a fairly novel idea, which hasn't gotten that much traction, but I'm a policy wonk, and of course, it's one of the first things I found. But political determinants of health. I want you to stop and think about that, and just let that soak in for a second. Political determinants of health, not the social determinants of health. If you have, that's the conversation that I'm sure at this point, many of you have participated in. But what does it mean to really be politically conscious? To be politically conscious is to be aware of the political determinants of health. It is to be aware of how service delivery is fragmented, and realizing that if you are functioning strictly in a prevention space and you're not considering people's access to care after they receive a diagnosis, then that's not politically conscious, right? A political determinant of health is being aware on some of the legal pressures on safety net health systems. For example, just tracking information of who goes through a hospital system or goes through the emergency room. To what extent are we collecting, or should we be collecting, information about immigration status? What if the disparities that we talked about are not related to ethnicity at all, but more related to somebody's specific type of immigration status? Would we know that? Would we know that without measuring it? So politically conscious medicine and research acknowledges what we don't know and realizes that there may very well be disparities that need to be unpacked, but maybe not in the ways that we've been accustomed to. Politically conscious medicine and research acknowledges that the way we get trained, the very way we get trained, makes a big difference in what we consider human rights and civil rights. So I want to ask how many of you have had different types of training opportunities around different social determinants of health, around barriers around race and ethnicity, structural factors. There are many things that we talk about in a civil rights context, which is usually premised on this idea of what are services that we assume should be accessible to everyone. But what we don't often consider in these conversations is that most of that work is almost completely removed from human rights types of efforts. And that means that so often, while we're advocating, for example, for improvements in the Medicaid system, we're often not acknowledging that there are entire groups of people that are not eligible and will not be eligible for Medicaid. And so the best of improvements in the Medicaid system won't address people that are not considered, that aren't considered entitled, where that's not considered an entitlement to them. So to what extent have you even talked about politics, the great taboo, and how that explicitly shapes your practice and training? What we don't measure, we're not held accountable to address. So what type of data are you looking at? And to what extent are you focused just on the problem here? Because again, part of what I've mentioned is these disparities focused frameworks that we have draw so heavily on this continual documentation of, hey, here's the problem. Here's another layer of the problem. Oh, we found that the problem was so much worse than we realized. Oh, now it's really, really bad. But at what point do we stop and say, can we observe at least when the problem doesn't exist? If our solutions aren't moving forward, is there a way to study what happens when it doesn't exist? So part of politically conscious approaches to research in medicine really requires this idea of shared accountability. Because if we acknowledge that the disparities in a group of people reflect not simply one person or one organization's failures, but represent a collective failure, then that means that we also have to share accountability in what that looks like. So the pictures that I'm showing you on the screen are from a research project that asked some folks in DFW and Houston areas to document their experiences as immigrants during the pandemic. And so these were a couple of photographs that were shared by a person who lives in an apartment complex, primarily of Central American immigrants. And so this is, so when she was explaining this picture and how it relates, she was explaining that this picture on the left where you see like a red cloth being hung out of a window, this is a symbol that the folks in the apartment complex had agreed upon, this universal symbol of kind of a red flag or red color as a call for help. As a call for help, that could mean we have COVID and we can't leave the house, or somebody we've run out of food, possibly a combination of those things. So in response to seeing this flag, the community that within this apartment complex had organized itself to leave basic food supplies at the front door of somebody to be able to provide them support that way. So what does this mean? Well, we can stop and we can be amazed at what normally most people's reactions would be to this, which is how amazing, the support, the mutual aid, the resilience, all of which are true, But I want to point out that shared accountability means that there's a reason why communities have had to be so resilient. Because if we acknowledge that having access to basic food supplies is that challenging for some people, that communities take it upon themselves to care for each other, that it's a politically conscious approach acknowledges the circumstances that led this community to need to depend on itself to that extent, but B, also acknowledges this as a strength and as something that can be nurtured, again, in a shared system of accountability. So shared accountability is a conversation that involves a lot of things, and we've talked about parts of that, how to collaborate across sectors, what are legal experts and social service professionals, what do healthcare providers, how can we create a more supportive medical and payer environment? Meaning, how do we get that message across to our communities? You are welcome here. And I want to make sure that that's very clear that there's a big, big difference in saying we welcome all people versus we welcome you. right? Those are two very, very, very different messages. And that's a really important thing to remember, that when we say we welcome all people, the communities that haven't been heard in the past don't see that as a welcome a lot of times. So I've talked about some of these ideas. I want to show you a couple of examples from a research lens for those of you that are thinking about how you might apply this, especially if you're more in a population health research space. But one of the most basic ways of looking at the health of communities, of groups of people, is to look at self-rated health with this health-related quality of life scale that is very, very widely used, developed by the CDC. And it asks people to rank their health, right, in very basic ways: poor, fair, good, very good, excellent. And this is actually a very consistent and reliable way that lines up well with other more objective measures of people's health. So what happens when you ask this same question of first and second generation immigrants? So what happens when you ask this question of people who were born in the US, or who were born outside of the US, or who have at least one parent who was born outside of the US? Well, just visually, if you do something that is almost never done, which is actually ask people their immigration status, you see some very significant differences. So this is from a survey that I developed, and again, I can talk a little bit more in detail about the broader scope of that. But when you look at how the distribution of health varies based on different types of immigration statuses, you see it doesn't line up consistently. It is very, very possible that what we consider to be good health or great health is very dependent on the people around us, is very dependent on political circumstances, and the ways that we measure it may not even be consistently applicable to other groups. What else is another example of politically conscious medicine? How we identify people versus how people identify themselves. So if you look, and again, we're in Texas, we're talking about immigration, we're generally talking about Latin American or Hispanic immigrants and persons. When you ask people about different aspects of their health, so let's say you're not just interested in their self-rated health, but you're also interested in their mental health and their physical health and their general functional ability to function and do their daily activities. We see big differences among people, not based on whether they define themselves to be Hispanic, but based on whether other people define them to be Hispanic. And so it is very likely here that people that consider themselves to be Hispanic but are not viewed as Hispanic may actually have higher levels of mental distress or higher levels of activity limitations. And the question of why, that's a great question. That's part of what we want to unpack. But the politically conscious approach here, though, is really careful about not assuming that being labeled as a certain ethnicity and self-identifying as that have similar impacts. Again, we similarly we think about what does it mean to be healthy, but we often assume that having access to health insurance or US citizenship will have an automatically good impact on health. But there are places where we see people that are not US citizens that report much higher levels or much better levels of health. They may report much stronger levels of physical activity, less activity limitations. So where are those pockets? A lot of the times when we see these types of statistics, we think, well, that can't be right. No, it can't be. It's not possible. Or a lot of times scholars will say, well, there's got to be a simpler explanation. Maybe folks are returning home, and that's why we don't see their negative health statistics and so on. But as much as we're explaining away what doesn't seem to make sense, we're also not looking deeply into it and realizing that there are pockets of strength, of resilience, and innovation that could very well point the way for our future interventions. And if you were to just chart and compare things like physical health compared to mental health, you would be able to notice, for example, that maybe if we look more closely at our data, rather than just focusing on one intervention on physical health, maybe we realize that there's a relationship between physical health and mental health. And maybe we find the point at which that starts to impact mental health. So we start to look at collaborative interventions of how that may look at intervening in one space in order to prevent impacts on another. Another thing that we often though look at, again, when things don't fit the pattern. In statistics, we love to come up with every endless way possible to smooth data out and make it fit something. But a politically conscious approach really stops and asks when it doesn't fit the pattern. Say that there are people who manage to remain in good physical health, even as their mental health worsens. If that is the exception, how do we cultivate that? Are there things happening in certain communities where it's not just about pointing to disparity, but if there's a certain levels of resilience and strength that due to difficult circumstances emerged, can we do better at partnering with our communities to understand and to be able to answer these types of questions? How do we promote people's health even as their activities become more limited? We, again, have so many assumptions about what works and doesn't work. But when we look at research and we really dig down and disaggregate and look at how things interact with each other, we find that we have a lot more opportunity to intervene. Let's see. So a couple of things, and I know we're wrapping up, we're running low on time, so I'll jump back and touch on things as you have questions. But a couple of things, one of the things that I really want to make sure to point out is that as we're emerging an interesting stage of the pandemic, as we're looking at responding to the different questions that have come up, the health disparities that have really been, that we've seen develop and expand, there's more and more a question of long COVID and the long-term impacts of our community, the long-term economic impacts. And so it's really important to contextualize that where you do live, those of you that live and work and play in Tarrant County, it's important to remember that as folks are dealing with the impacts of long COVID and the other effects associated with that, people to this day, to this moment as we're speaking, continue to live in a county that restricts people who are not U.S. citizens or lawful permanent residents from being able to access healthcare from the place of last resort. And that is very much an issue that we need to remain aware of and remain politically conscious as to what that means for us as practitioners and researchers. And so I will pause there.
Yes. Thank you, Dr. Nava, or Marcella. Thank you so much for a very inspiring presentation. This definitely has given us a lot to think about and to really be politically conscious of how we're providing care within the Tarrant County Hospital System. Questions? We will be taking the questions through the chat. I know there have been several comments that everyone appreciates your candor and compassion, and that this gives us something to think about as an organization. But any questions for Dr. Nava? So where do you see your research going next?
Oh my goodness. That's
a loaded question.
That's a loaded question for somebody that's especially early on the tenure track. We've got so many amazing projects that are happening, that have been really happening around this space, that a lot of what we are working on is trying to go after different pockets of funding to really be able to amplify the voices of the people in the community, to try to come up with some innovative strategies. We're looking at interventions with community health workers to do some education, looking at some grant opportunities to expand that, and to look at some of the different policy levers here to try to identify, maybe kind of a more complex and nuanced idea of what other counties are doing and where there might be other pockets of strength that we can observe. So all over the place. Yeah.
Yes. Well, we too are looking at community healthcare workers and looking at funding opportunities for building that program within the JPS system. So
Wonderful.
potential research opportunities.
Yes.
And I know that there was a question from Dr. Jay Haynes. Oh, I lost it in the chat. How can we better partner with FQHCs?
That's a great question. Well, I won't pretend to speak on behalf of FQHC. We do have FQHC in Tarrant County. For those of you that aren't familiar, federally qualified health centers, which receive federal funding in health service shortage areas to provide services. And FQHCs do not, due to their funding stream, they're not able to restrict services based on eligibility for insurance or immigration status or things like that. So with FQHCs, the roles of FQHCs, FQHCs are critical. So I think that's the first important thing. FQHCs are an important part of the safety net health system, just like JPS, just like our nonprofit hospitals and the public health department. But FQHCs are generally, at least I'll say in Tarrant County, they're within the same environment, fundraising environment that other organizations. So an FQHC may receive part of its funding from the federal government, but it's really important to remember that it is only a small part of its overall budget that it receives. And at the end of the day, it still has to really engage in heavy grant writing and fundraising to be able to expand those services. And in a political environment that is very fiscally and socially conservative, it's important to remember that an FQHC is also going to experience the same limitations that other organizations would experience. So I'll say, again, my opinion is that FQHCs are a critical part of this, but certainly not the sole responsible party. Just like JPS, certainly can't do it alone. FQHCs can't do it alone. And I hope that that's echoed, here, that there are many different departments and agencies that we could point to and talk about. But no single organization, hospital, healthcare system should or could really address the issues that we're talking about today. This is an issue for entire community. This doesn't just impact, again, this isn't an issue of immigrants or children of immigrants or the researchers here. This is an issue of everybody here, because the healthcare quality, the healthcare access of one group of people impacts the healthcare quality for all of us. And so it is in all of our best interest to make sure that we have a system where we're working together to share that accountability, where we realize we may not have the solution, but we need to be at the table discussing that solution.
Yes, very well said. I really like shared accountability. We need to remember that. There is another question that was posted in the Q&A. So just for the audience, you can post questions in the Q&A tab or in the chat tab. So from the Q&A, there, what are the first steps for action and change to become politically conscious?
That's a great question. I think one of the first steps is to really have a conversation about it. I think that is absolutely the first thing that we have to do. I do have a resource, and I'm happy to share and get to everyone afterward. There's a resource that I was able to develop called a Teach Out, which I was able to develop through my Robert Wood Johnson Foundation program, and it's hosted through the program Coursera. It's meant not as a heavy academic course, but really more of an introduction to the broader ideas of immigration, of health, of different political barriers. It includes a lot of interviews from some amazing local leaders like Amanda Arazola, County Commissioner Devin Allen, we Representative Mark Vesey. We have folks from Chamber of Commerce, from healthcare systems, and a lot of different perspectives there. So I would suggest as a first step is to, whether it's that resource or similar ones, really just have some quiet introspective time to realize what you don't know. Because I'll say that after 20 years of being in this space, it is, I remain so aware of all of these issues because it is simply part of who I am. It is part of my parents' lives. It is part of my family. but there is really, I can see that there is really no space, no consistent space for a lot of folks to have these conversations and feel that they can do so in a safe way, and feel that they can ask those questions that they may be scared or embarrassed to ask. So look up the information I'm happy to share, and just talk about it. Talk about it, break that taboo, be willing to ask questions, and be willing to stir the pot just a little bit. Just let's, if we can just all agree to stir the pot a little bit and just see, kind of what that reaction is, then I think we can probably have a better sense of how we need to work together.
Well, maybe that should be a couple of hashtags for this symposium. Hashtag stir the pot a little, and hashtag shared accountability, political consciousness. Several hashtags are coming out of this symposium. But we appreciate your ability to be frank and just open up this conversation. It is a conversation we do need to have, and to continue to have this conversation within our organization and across the DFW metro. So please share the training that you mentioned, and we will make sure that we can share that out via email when we send the survey for the research symposium.
Wonderful.
Yes. Well, thank you so much for participating as our keynote address, for providing the keynote address today.
Thank you so much for having me.
Yes.
This is very special. Thank you.